Hi, everyone. I'm Dellann Elliott Mydland, President and CEO of the End Brain Cancer Initiative. And our mission is to help patients with disease in the brain, with cancer in the brain and the central nervous system to receive the best care possible and to educate them about the necessities of considering a clinical trial and advanced diagnostics as part of their treatment options. And today I have the pleasure of getting to spend some time with Dr. Christian Grommes. He is a specialist in the disease known as PCNSL. And I want to tell you a little bit about him before he gets to talk, okay? He is a neuro-oncologist, an early drug development specialist at MSK in New York. I looked at his resume and you incredible work you are doing, incredible accomplishments, and your research and your publications from that research are vast. And I just want to say thank you to you because
thanks.
Truly, you really have dedicated your life to research and to this disease as well. So thank you. His areas of expertise are primary brain tumors, CNS lymphoma, central nervous system lymphoma, and brain metastases. We are so delighted to have you today, Dr. Grommes. We need more people, special people like you. Thank you. I also want to thank Curis Therapeutics for bringing us together, for investing in the disease of PCNSL and into this research, and for helping you and I and the End Brain Cancer Initiative with this educational video for patients and the PCNSL community and the distribution, which will be global, helping us with this project. So thank you, Curis Therapeutics. The third section is relapse and progression. We have time. I want you to know we're not rushed for time, so you can certainly explain this as much as you would like to. What happens if the disease comes back?
That is a very good question. When the disease comes back, we have multiple options depending on when the disease comes back in the journey of the patient. So if the disease comes back within a year of the original chemotherapy with methotrexate, that is a different situation than if the disease comes back 5, 10, 20 years after original methotrexate. So you can always use methotrexate again, the longer the time frame between the last methotrexate and the recurrence. So that is something we have done a lot. And now we have more options that are targeted agents, where we use something called a Bruton tyrosine kinase inhibitor, which is an oral drug that you can take, or immune modulating medications like the IMiDs, like lenalidomide or pomalidomide. That's also a drug that you can take orally. You can use chemotherapy with agents like temozolomide or chemotherapy. So these are all options that are outlined in the NCCN guideline. Now, again, there is no gold standard because we do have only limited clinical trial experience and no randomized trials that defines the right treatment options at this time. I think that we will see in the future that will change because there's an explosion of treatment options for non-CNS lymphoma, and they trickle into the CNS space. And so there's a lot of interest, a lot of potential avenues to go. And I think within the next 5 to 10 years, we see more treatment options that are also based on more data, clinical trial data.
So that's fantastic. I mean, I hear what you're saying is that there's more interest in research in this area for these patients, right, who are or will be in the future diagnosed with PCNSL. You know, that's pretty amazing, fantastic, and wonderful because this is an ultra rare disease. So it always warms my heart when I see industry and researchers, healthcare providers, doctors such as yourself, placing an amazing, wonderful focus and resources into this research into rare disease Thank you. Again, thank you. You mentioned something, and I don't know if our audience will understands this, so I'm wondering if you can explain targeted therapies a little more.
Yeah. The concept of targeted therapies is to attack a vulnerability of a cancer, the Achilles tendon of the cancer. In primary CNS lymphoma, we have learned that there is a pathway, the B cell receptor signaling pathway. So every B cell, which is usually the malignant cell, has a purpose when it's not malignant, and that is to bind to something and activate that pathway. And it seems that that pathway is usually upregulated in lymphomas of the brain. And by targeting specific proteins that are part of that signaling axis in these cells, the cells die. And so this is a concept in oncology that has been used in other cancers, in lung cancers, and also, lymphomas outside the brain, by using these very specific inhibitors to take out proteins that are important in these signaling axis, and then the cells die. But that's also their Achilles tendon, is if you only have one cell that is able to avoid dying from this medication, these tumors grow back. And that is the downfall of these targeted agents at the moment, is that there's a high response rate, but the time that response maintains is short. So that's why I think, again, in the future, what we want to see is combinations of these agents with conventional chemotherapy or different agents. So you target multiple Achilles tendons of a cell to then, kill them all. That will be the idea.
That is fantastic. You mentioned also, I think you mentioned phase 1 clinical trials, phase 2 clinical trials, and phase 3 clinical trials. Would you please explain each one of those?
Yeah, that's a very good, yes, I should explain the phases of the trials. When you have a new drug that has been developed in the laboratory, you have no experience with that in human beings. You have an idea about the toxicity, sometimes from preclinical studies, so you start at phase 1. The phase 1 is all about finding out what is the dose that I can safely deliver to a patient. Not about, does it work? Does it kill cancer cells? None of that. It's like you start with a low dose of the drug, you go up until you hit toxicities, and then you stop. That is the phase 1. Now, why would I, as a patient, go into a phase 1? Because it's all about toxicity. Sometimes these phase 1 trials have very exciting drugs that are actually very effective. So you have first dibs into that. This is maybe something I would not immediately jump on if I'm newly diagnosed and have an established treatment regimen. That is the phase 1. Well, phase 2 now takes that drug at the dose that we know is safe, because we established that in the phase 1, and now give it to patients and see, does it actually make an impact on benefits and clinical benefits, outcomes, responses, and these things. And we usually compare that with historic controls. And if it's promising, we take it to a phase 3, where we combine standard of care versus the new drug, or standard of care plus the new drug. And so that will be a phase 3, that if the phase 3 shows that the new drug is much better than your standard of care, then that will become the new standard of care.
Fantastic. Thank you. Thank you for explaining that. I know a lot of people don't understand clinical trials.
Yep.
And I know that there is a lot of people are fearful of clinical trials. And I feel like it's only because they don't understand them. There's not enough education about clinical trials.
Yeah.
And your explanation of phase 1, 2, and 3 was fantastic. So thank you so much.
You're welcome. If I may say one more thing about the trials, if you allow. There's every patient that enrolls in a clinical trial does that voluntarily. So there should never be pressure to enroll in the clinical trial. There's an informed consent form that is written in a way that every patient should understand what this all entails. And I always say that to my patient. It's not buying a house. You can always step away from the trial if you don't like the trial, if you think it's too much traveling. And it should and will not affect your treatment afterwards. Another thought is, in a phase 3, for example, you have a control arm or a placebo arm, depending on what it is. And then also the question is, why should I enroll into something like that? There is a benefit of being enrolled in the clinical trial, because even though I just talked about this, how closely we monitor our patients, there's an even more scrutiny on the surveillance of these patients to make sure they're safe. So I think that is also of benefit sometimes for our patients. I think the message here is it's up to the patient to enroll, and the patient can always step away if they want to.
I completely agree. The other thing too, and you mentioned this, the informed consent form, which is something that has to be signed before anyone can enter into a clinical trial. It is giving the patient's approval of, yes, I want to enroll into this clinical trial. And like you said, you don't have to stay in the clinical trial. Researchers and doctors and physicians would hope that you would, but if there is a real reason for you to step away from the clinical trial, you have that ability 100%.
Yeah.
One of the things, speaking of informed consent forms, that I personally would like to see as a patient advocate and a person who works with many patients all the time, I would like to see those forms to be patient friendly in the language, because they're not. And there should be that big, long legal form that people are like afraid to look at and sign, even though it's fine. And then there should be this like one pager that actually explains it in patient friendly language. I mean, that would be beautiful for the patient.
So these informed consent forms should be written in English of an 8th grader. So
they should be.
To understand it, yes. They are sometimes very thick, 30 pages and more, I know. But I agree with you. There is actually, at least at our institution, a page or two where it's like just a general overview of why this is done, and then in more granularity, the details of all these things. I also think that every patient should not feel rushed. They should have enough time to read the consent form and then to ask questions. And so there's no penalty in taking your time reviewing these things and asking questions about the trial.
That's great advice. Thank you. Before we move into a discussion that's even deeper related to clinical trials, I'm wondering, our audience may not be aware of what the NCCN guidelines are, what they are, one, and two, of course, what they are for PCNSL. Would you take a moment to explain those?
Yeah, so these guidelines are for rare diseases where we don't have larger clinical trials to guide us. And so there are disease expert panels that come together that discuss, data that has been published or that discuss experiences with drugs in its patient population, and then they vote. They put it on the guidelines or not. And so it gives physicians in the US, well, also worldwide, but mainly in the US, the ability to use agents that are not FDA approved for this disease, but guideline recommended, to then go to the insurance companies and say, we really want to use this drug. Again, it's not one person. It's a panel. It's, again, a very diverse panel from different walks of the way in the United States with disease experts. So not just one region versus another, that comes together on a yearly basis to define what is a good guideline in treating these patients. And there are some treatments that are in the guidelines, but they're not highly recommended versus others that are highly recommended. And there is an evidence to it. There is the evidence that there is clinical trial data based on randomization. Then the next step is clinical trial data, and gets less and less obvious. That the data gets less and less concrete. And so, but it gives us as treating physicians a little bit more leeway with particular insurance companies.
That's interesting. Okay, so particularly with insurance companies. So, question, if the drug is within, or the treatment is within the NCCN guidelines, would we expect insurance companies to cover that treatment option, that drug, that diagnostic, that whatever?
Again, depending on the level, yes, there are some. Again, the higher the recommendation level, the more likely it is that it's covered. So, but yes, that's where the NCCN guideline comes in to help us with that argument. Yeah,
that is fantastic. Thank you.
Yeah.
One thing you mentioned before, and I'm wondering if you can explain it just a little more. Within clinical trials, you talked about the treatment, the drug, the whatever it is within the clinical trial that's being tested, researched, but you also talked about the word placebo. Can you explain?
Yeah. Well, so particularly in phase 3 trials, the patient as well as the doctor don't know what treatment is given, and that's the whole purpose, that you don't bias patients and responses. And that's where placebo comes in. There are some trials that have placebo as a treatment. So it's either observation versus something, but the patient on observation gets a placebo. That's not usually the trials that we have in neuro-oncology. In neuro-oncology, it's the standard of care plus placebo, plus the standard of care and the trial agent. The purpose of that is to reduce bias by us and the patient knowing what they're taking. It's not really very common that we see that in neuro-oncology, to be honest. But that is what the placebo is there for.
And then, something else maybe would be interesting for the audience that's going to be reviewing this patient disease educational video. Within clinical trials, can you please explain for those clinical trials that have that crossover protocol built in, what is that?
Oh, it's getting a little more complicated, isn't it? But yes, what is the crossover? So, for example, if you are on a study that has a placebo or that has a different treatment arm without the agent, you can say at the time that you have a progression or the treatment is no longer working for you, we unblind you, we find out what you have, and if you have not had the drug, you can roll into or you cross over into the drug group. Now, this is obviously helpful when you look at, it's helpful for the patient because you know that you sign up for a trial and you will get the drug earlier or later. Sometimes it can be a little bit difficult to interpret these results because, when it comes not to response, but to the overall survival, you might just not be clear what is working and how and what is contributing. But that is what the crossover is. It just allows patients that have been randomized to the non-treatment is the wrong word, but the arm without the novel agent to then receive it later. Yeah.
Wonderful. One more thing, definition for clinical trials, randomized.
Yeah, so randomized is flip of a coin, isn't it? So there is generally nowadays a machine that, or computer, tells us in which arm the patient goes into, and that is randomization. And so it's not me that determine, again, being biased, this patient gets this treatment or that treatment. And so that is randomization. And sometimes the randomization is just like that, or we kind of put an emphasis on making sure that the randomization follows some patterns, that we have not just old people in one arm and young people in the other, or very healthy people on one side versus very unhealthy in the other. So that depends a little bit on how the trial defines the randomization process. But randomization is literally a flip of the coin, which arm you get into.
Thank you. Are you able right now, and right now is September 26, 2025. Are you able to give a brief on the current clinical trials that are recruiting? They're open. They're recruiting for patients right now. And we can just talk in the US if you want. Are you able to talk a little bit about those?
Yeah. So in lymphomas, primary CNS lymphomas, there are basically two groups of patients, and that is I think true for all brain tumors. There's the first line trials and there is the recurrent refractory lines. And so for first line, it's all about adding stuff to methotrexate. That's what's going on at the moment, to see if novel agents or novel treatment options make a difference. Also, there are some trials where we look at different consolidation regimens to see if they make a difference. In the recurrent setting, it's all about targeted agents, BTK inhibitors, gluten tyrosine kinase inhibitors, targeted agents combined, targeted agents with chemotherapy. There's some CAR T cells. We haven't talked about CAR T cells yet, but that's a treatment that has been established in lymphomas outside the brain to take the patient's own T cells out of the body, modify them to recognize the cancer cells and put them back in. So that's the idea in CNS lymphomas too. There's also bispecific antibodies that have been established outside the brain in lymphomas that will have a role in trials for the CNS lymphoma patients. And obviously agents that are antibody drug conjugates. Long word to say we attach something like a chemotherapy or a radiation source to an antibody that then finds the cancer cell, binds to the cancer cell, and treats the cancer cell right there locally. See, these are new kind of options for trials. And so I think the general direction goes into very targeted specific treatment and how to engage the immune system. I think that's the bigger direction this all heads. Yeah.
Okay, thank you very much. Very much. Okay, so that wraps up section 3, which was relapse and progression.